Thanks very much. I'm very pleased that we have our speakers today who are going to be providing updates on the two signature studies that we're conducting with the Autism Intervention Research Network on Physical Health, or AIRP. One study is regarding sleep and iron status and the potential for treating sleep problems in autism spectrum disorders with iron. And the second study addresses a novel treatment for overweight in children who are receiving antipsychotic medications, another common issue that we encounter in this field. Our first presenter is going to be Dr. Ann Reynolds. Dr. Reynolds is a developmental behavioral pediatrician at Denver Children's Hospital, is one of the lead autism specialists there, and an associate professor of pediatrics. So I'm going to turn things over to her for her presentation.
Thanks, Dan. I'm really pleased to be here today, and hope everybody else's weather is a little better than ours right now. You can go to the next slide. So the objectives for this morning are to talk about challenges in multi-site research and also binational research. Challenges of an investigator-initiated FDA trial, identifying effective research recruitment strategies, and improving study design and implementation methods. And the 4 sites involved in this study are University of Colorado, Vanderbilt, Rochester, and Toronto. And so the objectives for the trial are to conduct a randomized placebo-controlled trial of oral elemental iron treatment for insomnia in children with ASD, to examine the value of the PAM-RL, which is an actigraph designed to measure periodic limb movements in sleep, to look at whether it will predict response to treatment with iron, and to evaluate daytime behavior and quality of life before and after treatment with iron. Oh no. One of the reasons that we wanted to conduct this trial is that restless leg syndrome appears to be pretty common in children, occurring in about 2%. And there's been a lot more awareness of restless leg syndrome in children over the last 5 to 10 years. And recommendations actually have come out that anyone with a restless leg syndrome and a ferritin level less than 50 should receive 3 milligrams per kilogram per day for 3 months of treatment with iron. And so in our patients who have autism and may have challenges with communication, a lot of people were using iron treatment empirically to see if it could be helpful for those children. And there was actually a study done by Kara Dosman and Wendy Roberts in Toronto where they treated, it was an open-label trial in children with ASD with low to low normal ferritin and restless sleep, and they were able to see an improvement in sleep with treatment with iron. And we also, there have been a lot of reports of low ferritin or iron deficiency in kids with autism, but none in the United States until we looked at that in our diet and nutrition study, and we found that about 8% of kids with ASD had a ferritin less than 12, and 90% had ferritins below 50. Next slide. So I'll just go through the specific aims and hypotheses pretty quickly. So we wanted to evaluate the effective treatment with oral elemental iron versus placebo in children ages 2 to 10 with ASD, insomnia, and ferritin levels between 17 and 49. That 17 is the cutoff for our central lab, and so we didn't want to randomize children to placebo if they actually had low ferritin levels. We felt like those children would need to be treated no matter what. And so hypothesis 1 was that children with ASD with ferritin levels between 17 and 49 will show improvement in sleep onset and sleep maintenance insomnia as measured by wrist actigraphy after treatment with iron, 3 milligrams per kilogram per day divided twice per day for 3 months as compared to placebo. Aim 2 was to look at the evaluate periodic limb movement index, or periodic limb movements per hour, as a predictor or mediator of response to iron treatment using the PAM-RL actigraph. And so we predict that children who have higher PLMI prior to treatment will experience greater improvements in sleep with iron treatment over placebo, and that children who experience larger decreases in PLMI over the course of treatment will experience greater improvements in sleep onset and sleep maintenance, regardless of what treatment group they're in. And so specific aim 3 was just to evaluate daytime behavior and quality of life before and after treatment. So we will use a sleep clinical global impression scale, and then we'll evaluate attention and hyperactivity with the SNAP-4, irritability with the ABC, repetitive behaviors with the RBSR, and overall quality of life. So our population will be about 50 children per site over 1.5 years for a total of 124 children who are randomized. We have a pretty complex screening process, which has been one of our challenges, but we feel it'll make our final population more likely to be responsive to iron treatment because we've ruled out other issues that might be causing their sleep disturbance. These children are going to be recruited not just from the ATN registry, but from other research and clinical databases at the 4 sites, and the ages are 2 to 10. So we'll use ferritin as measured by the central lab. We'll also look at CRP, which is a marker of inflammation. If ferritin's an acute phase reactant, and so if there's evidence of inflammation, it may be falsely elevated and inaccurate. Our primary outcome measure is wrist actigraphy, and so that's the typical actigraphy that we used in the sleep education study, and that just will look at sleep onset delay and night waking. But we also will have the PAM-RL accelerometer for children over 5 and children who also don't mouth objects. And then a sleep diary to make sure that our actigraph information is consistent with what the parents are reporting. We'll use the Child Sleep Habits Questionnaire and the Family Inventory of Sleep Habits as outcome measures as well. And then for the study, we actually developed the Sleep Clinical Global Impression. Beth Mallow and the ATN sleep team worked hard on that, and And so we'll use that as a secondary outcome measure. We found in the sleep education study that there were children who had significant improvement in sleep, but it was sleep resistance, and so we felt like we wanted to be able to measure improvements that may not be picked up by the actigraphy device. And then we know that sleep deprivation can lead to irritability and difficulties with attention during the day, and so we're going to use the ABC and the SNAP-4 to evaluate that. In the sleep education study, we found that one of the measures that showed greatest improvement with improvement in sleep was the repetitive behavior scale. So we added that in, and then we'll look at the pediatric quality of life. So basically, our screening process requires confirmation of eligibility. We have a list of inclusion and exclusion criteria that include looking for any treatable medical conditions that might be affecting sleep. So untreated gastrointestinal issues like constipation or reflux or snoring, which really need to be treated prior to enrollment in the study. They obviously have to meet our criteria for insomnia. They have to have a ferritin level between 17 and 49. They also can't be anemic. And then we collect the behavioral measures. And prior to randomization, they also will receive an hour of sleep education followed by 2 phone calls so that we aren't evaluating the effect of iron in children who have behavioral issues as the source for their insomnia. And then they'll have actigraphy prior to randomization. So we expect that about 30% of children will drop out during this screening process because they'll respond to sleep education based on our sleep education study. We do feel like, though, that study did not look at night wakings. In this study, it's part of the inclusion criteria, and so the sleep education is not as successful. It still can be successful for night waking, but it's not as successful, and so, but we do expect that we'll have some dropout. Then the children will be randomized to oral ferrous sulfate or placebo. We work to find a placebo with a natural dye in it. So we're using turmeric. The treatment phase will be 3 months. They'll have study visits monthly and phone calls at least every 2 weeks. They'll have 1 phone call after the first week, and then they'll have actigraphy post-treatment. So some of the challenges that we faced are, one of our biggest hurdles was that we weren't sure if we needed an IND for a study looking at iron. And the only way we could find out was to submit the protocol to the FDA, and then they would tell us if we needed an IND. So we worked really hard to put a protocol in, but we did it prior to the scientific review committee and to our investigator meeting. So we ended up making changes to the protocol. And so when we had to resubmit to the FDA the new protocol, the number of changes was significant and required a lot of explanation and formatting in order to make the track changes version readable. so the other thing that occurred over the course of initiation of the study is that our IRB implemented a telephone consent process for pre-screening. Prior to that, the FDA would not allow you to collect any information about subjects prior to consent. And so you ran the risk of bringing kids in who clearly weren't going to meet criteria because you really couldn't talk to them about the inclusion-exclusion criteria prior to coming in for the visit and getting consented. And because we're going to be recruiting from not just ATN subjects who we know well and have a clinical relationship with, we felt like we needed to do this. It's also didn't feel right to have patients drive in, schedule an appointment, drive in, and just to find out that they had something that, you know, would not allow them to qualify for the study. And this has obviously been an issue for others, and so they implemented this telephone pre-screening, which so you're not waiving consent, but you're waiving documentation of consent. So you basically consent the family over the phone to go through the pre-screening questions, and then if they come in, then that you do the regular consenting process, and then you're supposed to ask those questions again. If they don't meet criteria, then you shred that information and then just document that you pre-screened a patient. And so because this was a new procedure for the IRB and for everybody, there was a little bit of it was a little tricky to make sure we did it right and all the language was correct. But I think it's going to be excellent, and it certainly feels much better that we're not bringing patients in just to turn them away. We had to identify a central lab because we learned from the diet and nutrition study that the different cutoffs at different labs can be difficult to interpret. We also created new measures based on lessons learned from the sleep education study, and so we wanted to make sure that even though our primary outcome measure is the actigraphy, or the sleep onset latency, or the wake time after sleep onset, which would be the night wakings. We also wanted to be able to tell if there were improvements in sleep that wouldn't be measured in that way, like resistance at bedtime. We also had feedback that we probably needed to have some way to look at how well the parent was actually implementing the sleep education strategies, and so we developed a questionnaire to try and sort that out so that we would feel comfortable that we had the behavioral issues had actually been addressed. And then we also Terry Katz worked on that, and also on a restless leg questionnaire for kids, which is kind of a smiley face pictures about symptoms. Okay, next slide. So some of the regulatory challenges are that, you know, there are IRB at multiple sites. There's also FDA and timing when you make changes to IRBs and then to the FDA. They all kind of, they need to follow each other pretty quickly. We identified safety concerns. So because iron is dangerous in overdose, we decided to make sure the bottles weren't any bigger. Only had a week's worth of iron in it so that no one bottle would be a potential for overdose or significant toxicity in each child. Developing a manual of procedures and monitoring procedures for a clinical trial is quite a difficult task, and so that took a lot of time and effort on the part of our project manager to get all of that together. Putting together a data safety monitoring committee was not that challenging, but we tried to do it through a professional organization, and that was extremely expensive. So, but we were able to get that set up. Doing trainings over the phone and it can be a little bit tricky with everyone's schedule, and then obviously documentation of all these trainings needs to be something that you're working on from the very beginning. Multisite challenges obviously are communication. Standard procedures can vary between sites, and so even language like visit numbers was a little bit tricky because a lot of people would consider a phone call a visit. So we had to sort through a few of those kind of things. We have pretty prolonged screening procedures prior to randomization and sorting out the best way to manage kids who may qualify for the study eventually, but are currently having symptoms like snoring or gastrointestinal issues that need to be addressed first, and how to manage that. Different IRBs have different regulations, and so even though consent can vary from site, we found that there was some language at Vanderbilt that was really more appropriate for a pharmaceutical industry trial as opposed to an investigator-initiated trial. Setting up the database and the ECRFs took a lot of time and iterations with sign-offs, and then grants and contracts is difficult with the subcontract awards. We particularly had difficulty because we had to subcontract to Children's and the primary grants through the University of Colorado.
And we're going to need to wrap up here.
Okay. So recruitment is difficult. We've had about 1% return on sending out flyers to patients. The issues with medical comorbidities not being adequately addressed has been an issue, and so we feel that we're probably definitely going to need to look at recruiting directly from clinic. I think I just have one more slide. And so right now we have 20-plus kids that have been pre-screened. We've had 4 consented, and we've had 3 screen failures, 1 because the ferritin was low and 2 because they were snoring. That's it.
Great. Thanks very much, Ann. I think we've got time to take a couple of questions here before we move on to Jeremy's presentation. And Alex, I can't see the attendees, so I don't know if anyone's raising their hand or not.
Yeah, let me just take a quick look here. I see Claudia Brown. I have unmuted you if you want to ask your question.
My question was answered. Thank you.
Okay, thanks. Okay, well.
Okay, one of the things I think is interesting that we found here that it pertains to our network, Anne is having trouble recruiting because many of these children have already been treated, but also many of them have other problems that have not been adequately treated, in particular symptoms and signs of obstructive sleep apnea. I think one of the things that we get out of this study, if nothing else, is that attention to sleep problems and refining some of the questions that we use in our review of systems for children and adolescents on the spectrum is probably going to be to pay some special attention to these sleep issues. So I thought that was very interesting. Thanks very much, Anne. It was a very nice presentation. At this point, we're going to move on to our second presentation from Jeremy Veenstra-Vanderweele, who is a child psychiatrist at Vanderbilt University and one of the co-PIs on our ARP Metformin randomized clinical trial. So I'm going to turn things over to Jeremy at this point.
Great. Thank you, Dan, and thank you, Anne, for a very helpful presentation. We anticipate we also will be looking toward recruiting challenges, but we are now just headed to where we hope we'll be able to recruit soon. So I'm going to provide some overview on behalf of Evdokia Anagnostou, who is the overall PI, and then talk some about some of the challenges that we've dealt with. This clinical trial grew out of the Psychopharmacology committee within the ATN. It is based at 4 sites at Toronto, Pittsburgh, Vanderbilt, and OSU, together with Nationwide. And it is a randomized double-blind trial of metformin to decrease weight gain associated with atypical antipsychotic use in children with ASD. So I'm first going to talk about what we currently know about psychopharmacology in ASD by way of background and how this grew out of the Psychopharm committee. Then talk about current data on metformin, and then finally review our study design as well as the challenges that we have dealt with. So the review of existing treatment emerged from a systematic review conducted here at Vanderbilt by our Evidence-Based Practice Center. That review was really focused on young children, so children aged 2 to 12, and then there was a follow-on review of children, adolescents, and adults 13 to 30 years old that I'll mention briefly as well. It focused on all interventions, but I'm here going to just focus on the medical side. Importantly, the review was limited to studies that were published between 2000 and 2010. That's something to sort of take into account when you're thinking about our findings. And it excluded medical studies with fewer than 30 participants. Really the intention here was to focus on best evidence, not on exploratory or pilot studies. The primary result of the review of medications was that there was really only one class of medicines where you could say that there was sufficient evidence to draw any sort of conclusion. I guess the exception there would be secretin, where you could very clearly identify that it doesn't do anything at all. The only medicines that had enough evidence to say that they were effective were aripiprazole and risperidone. These are not surprisingly the 2 medications with indications from the FDA in autism spectrum disorder. The FDA approvals are for quote-unquote irritability. I think it's important to note that that corresponds to a subscale of the aberrant behavior checklist, and that subscale is more appropriately termed irritability, agitation, and crying, which was how Mike Amon initially termed it. So these are not kids that are just grumpy. These are kids that are agitated, aggressive, oftentimes showing self-injury, very distressed. Importantly, these medicines also showed significant benefit for hyperactivity and defiance, although that's clouded a little bit by sedation due to these medicines, but also for stereotype behavior. This is one of the primary symptom domains of autism, repetitive behavior, and so it may be that these medicines do provide some movement on that domain, although it was never the target of treatment. This is an example from the first study of risperidone, randomized controlled study published in the New England Journal of Medicine from the RUP group. And you see that the effects of risperidone are really quite marked. You see much improved or very much improved percentage here on the y-axis. Placebo only achieves about 11% ratings of much improved or better, whereas risperidone over time comes up to around 75%. So really substantial benefit. And then if you look at irritability scales, here with the aberrant behavior checklist irritability subscale, you see a decrease, mild decrease with placebo, substantial decrease with risperidone, coming down into the range of 10, and it's very difficult to see any of these studies that get down below that range. So it isn't that they completely eliminate symptoms, but they do lead to substantial improvement where a child may go from needing a self-contained classroom to being able to be in a typical classroom through some portion of the day. Unfortunately, these medicines really need to be reserved for kids with substantial and impairing symptoms because they're associated with significant side effects. So here we're talking about weight gain, and that's really the target of this study, as well as sedation and extrapyramidal symptoms. There's been an open question about how to approach weight gain in folks who are forced to take atypical antipsychotic medications to control behavior or psychiatric symptoms. The best data to date are really for metformin plus lifestyle, but this is primarily based on adult studies. Metformin, as I think most people are familiar, is usually used to treat diabetes. It decreases hepatic gluconeogenesis and increases insulin sensitivity. And if given to folks with weight gain on atypical antipsychotics, you can see here in red the placebo group continues to gain weight at a pretty good clip across 6 months. And here from data from Wu and colleagues, you see a substantial decrease in weight on either measured in kilograms or body mass index in folks who are taking metformin. This is in adults and is in adults with either schizophrenia or bipolar disorder. So it's a very different population. When you look at the aggregate data in meta-analysis, the data are supportive of a benefit for metformin in contrast with placebo across now 7 randomized controlled studies, not including the study on the previous page. So substantial evidence suggesting that this may be helpful, but again, most of this data is in is in adults. There's one randomized controlled study that was published in children. The study is from Klein and colleagues back in 2006. These were not children with autism spectrum disorder. It was a general group of children between the age of 10 and adolescents up through 17. And most of these folks were in the adolescent age range. And you see a similar pattern with continued weight gain on placebo in contrast with a mild weight loss here indicated. And actually this particular slide shows insulin resistance, but it's a neat parallel with weight gain and with body mass index as well. So our question, given that children with autism spectrum disorder are generally the youngest children who are exposed to atypical antipsychotics, and that this is actually really common with 50% of kids or more taking psychotropic medications by 10 years old, that we really wanted to know if this would work in the ASD population and wanted to extend this down into a younger age group. We also thought it was important to look in ASD because the most common complaints or side effects in these studies were GI complaints, and that's a common problem in autism already, so we wanted to know if these medications were tolerable for individuals with autism spectrum disorder. So our first hypothesis was that individuals taking metformin would experience who have gained 10% of their body mass index and starting therapy with the atypical antipsychotic, extending to age 6 to 17 in contrast with the earlier studies, and also looking for stable doses of concomitant medications. We're excluding essentially folks who we think are not able to or not likely to tolerate metformin either due to prior exposure or known medical problems, as well as medications with interactions. We're also avoiding bringing in folks who are currently taking another medication to target weight loss, as well as folks who are planning, say, a new diet in the near term that will have a similar targeted outcome of weight loss. And here it is presented graphically. We're looking at children coming in, being screened, being randomized, and then our outcomes are body composition, so weight and BMI, as well as fasting metabolic parameters, looking at a number of lab values that I'll show in a subsequent slide. We also, because we acknowledge that it may be difficult for some families to think of randomizing to placebo, want to give everyone the opportunity to have metformin at one point, so we have an additional 16 weeks of open-label treatment at the end. The medication itself has been the most challenging part of the trial so far. We made a decision early on that we were going to try to use a formulation that was already in existence, Riomet, which is manufactured by Ranbaxy Pharmacies. They have assured us over and over again that they want to do this, but there have been quite a lot of challenges in working with them over time. We wanted to use that instead of trying to reformulate because we were concerned that it might be difficult to match placebo to drug using our own liquid formulation, and they have developed a formulation that is quite tolerable to most folks over time. If you look at our dosing range, we have a lower total dose accelerating to 500 milligrams twice daily in children 6 to 9 years old, and a higher dose paralleling the Klein study in individuals in the older age range. Like the sleep study, we need to have a gold standard diagnostic at the front end. If they're in the ATN, that's straightforward. If they're not, that's a little harder. So ADOS, DSM-4 criteria, and a Stanford Binet. We then also want to have a sense of baseline behavior using the CGI and the aberrant behavior checklist. And then quite a number of screening labs to be sure that both they are safe to enter the study, and also we have baseline values to compare the endpoints to. We also do a thorough medical assessment at the front end. The evaluations across the study include our primary endpoints in body composition, height, weight, BMI, and abdominal circumference, but then, as I mentioned, also behavior ratings, fasting metabolic parameters, looking at glucose, insulin, lipid panel, and then also looking at safety across the course of the study using a structured safety monitoring uniform report form to really capture all potential adverse events in the style of a detailed review of systems. The evaluations include both efficacy measures and the BMI index Z-score will be the primary outcome measure. Assessing the secondary outcome measures over time, including, as I mentioned, weight, BMI, and abdominal circumference, and then looking at fasting metabolic parameters, ratings of behavior, and so forth. I should note on this slide it's important that because we have changes in expected BMI across age, we opted to adopt the Z-score as the primary efficacy measure. And this took quite a lot of back and forth, but this was decided after some debate. We have follow-up visits initially at 2 weeks, then 4 weeks, 8 weeks, 12 weeks, and 6 weeks. Initially, we're increasing the study medication over time and wanting to be sure we don't see significant adverse events. So that takes us to some of the hurdles that we've experienced so far. So unlike the sleep study, we really had to delay the IND application until we had all the details in hand from Ranbaxy. This took well longer than we wanted it to take to get all those details in place, but they needed to provide us the information for the detailed formulation and dosing. That meant that our protocol was essentially finished by the time we were submitting, and the submission to the FDA resulted in a quick IND exemption that we were relieved to receive. Health Canada, in contrast, did not give us an exemption, although we received approval to proceed. That raised some interesting issues in that all of the sites are considered part of the trial and theoretically regulated by Health Canada, so we have to all follow their regulations, even though those sites in the U.S. are also operating under an IND exemption from the FDA. It also meant that we had to complete an additional contract where we all agreed to follow the guidelines as outlined by Health Canada and as managed through the University of Toronto, which gave some of our contracts offices fits as they tried to understand how there was separately a contract with Mass General to conduct the study and a contract with Toronto to follow the rules. We also, because of the IND exemption granted here in the U.S., were able to get the IRBs approved at 3 of the 4 sites, but not the central site, which is still pending because they had to wait for Health Canada approval. The primary challenge that we've dealt with is really at the level of Ranbaxy. We are still waiting for them to distribute the study drug and placebo. It seems that they don't have much experience. It's a very small fine too.
Great, thank you.
So I found it's an interesting aspect that in both studies we've had some perhaps unexpected difficulties with INDs and regulatory issues that have slowed us down. Another problem has been the issue of consent and IRB approval crossing multiple sites, and the difficulty we've had getting the multiple IRBs to agree on a protocol, a common protocol, and a common consent form.
Yeah, I would say that that's a challenge. We've done a lot of back and forth as one IRB or another has asked for something to be changed. The latest and greatest is that we are actually collecting blood for DNA so that we can go back and look at potential modifier genes that may affect response to metformin. And that is handled very differently from site to site and has caused some difficulties in Toronto.
I think Steve Cook might have a question. Alex, I can't see the flags. Are there any other hands raised?
Yeah, so Beth Mallow, you just raised your hand. Go ahead.
Okay, am I unmuted?
Yep, there you are.
Yeah, it's Beth Mallow. I wanted to commend Ann and Jeremy for doing wonderful jobs and to address that in our NeuroNext network, which is an NINDS network that about 8 of the ATN sites are in. It's for all neurologic diseases, not just autism. We actually have a central IRB and other infrastructure things that really can help facilitate these trials. So, you know, if our ARP ATN continues to have several renewals, we may want to think about a way that we could do a central IRB and also some other infrastructure type things, Dan, because I think that these problems are really common to many of the studies. I think in our parent education study that we just completed, we had similar challenges with